Following treatment with chemotherapy, physicians and patients have the option of delaying any further treatment until the time of disease progression or recurrence. In this setting, after a partial or complete response, a patient would then enter a treatment-free period, also referred to as watch and wait. When we talk about maintenance treatment, it would be putting a patient on a therapy after completing their treatment chemotherapy. And the goal of this would be to try to lengthen the time between the end of treatment and their next recurrence. In the NOVA trial, the PARP inhibitor was not given in the chemotherapy phase. It was only given after the completion of chemotherapy following a PR or CR. So this is really more appropriately described as switch maintenance treatment. Now, given that approximately 50% of patients who go on to a PARP inhibitor maintenance trial have disease at the time that they go on the PARP inhibitor, i.e. they've had a partial response, the lines between maintenance and switch maintenance become blurred. When trying to decide whether to put a patient on PARP inhibitor maintenance, I think it's important to consider a few things. It's important to consider the clinical benefit, the side effect profile, and quality of life. Now, currently there are 2 PARP inhibitors, niraparib and olaparib, that are FDA approved in the maintenance setting in patients with platinum-sensitive recurrent disease. The patient population where the maintenance therapy should really be considered is in patients with platinum-sensitive recurrent disease, given that this is where it's FDA approved. In the PARP inhibitor trials in the maintenance setting, quality of life was similar between the PARP inhibitor group and the placebo group. But it's important to individualize the treatment to every patient sitting in front of you. We know that niraparib tends to have an effect on platelets, and a thrombocytopenia is a common adverse event seen. So it's important to know how to manage that in those patients that are receiving this drug. And with olaparib, you also see increases in creatinine, which we need to be aware of when looking to what patient populations to treat with this drug.
I'm often asked about using a maintenance type strategy versus a watch and wait strategy for our patients with recurrent ovarian cancer that have achieved either a complete or partial response after platinum therapy. And there is some evidence that platinum is damaging the DNA, and it's actually good to couple that with immediate use of the PARP inhibitor. So the scientific and the in vitro rationale is capitalize on use of the PARP inhibitor when maybe it will work best. So the immediate maintenance strategy has been employed by many of the manufacturers, and with a logical design to see if we can best capitalize on the damage done by the platinums and then use the maintenance PARP inhibitor to get their best results. When we think about sequencing of agents for treatment of ovarian cancer, using these agents early makes some sense, especially if we're following use of a platinum. The patients, hopefully, that damage done by the platinum can be capitalized on by the use of the PARP inhibitor. So giving these usually after second or third line makes sense to do for most of these patients. When people ask me about the standard of care for management of these patients, is a PARP inhibitor a part of the standard of care? It certainly is. It's part of the NCCN guidelines, that this is what I would like to say within the standard of care. You know, the one thing we know is no single ovarian cancer patient is always created the same. They have differences in response to their platinums, difference in toxicity, difference in goals of whether they want to travel. So any one clinical scenario doesn't always fit, but this option is certainly a very good option for our patients that meet criteria for use.
PARP inhibition has shown to have some very valuable benefits for patients, particularly for those that have recurrent ovarian cancer that is platinum sensitive. I personally do not believe that PARP inhibitors are quite yet the standard of care yet, because we still have to define those patients that truly benefit from PARP inhibition. I think that We need to gain more experience with PARP inhibition. I think we need to identify those patients that truly benefit from PARP inhibition better. Those trials are all ongoing. The material that we have from clinical trials is extremely valuable to ask questions like this. Who are the patients that, based on the molecular profile of the tumor, are having the greatest benefit from PARP inhibition? We also have to consider that PARP inhibitors are expensive, with an average of about $10,000 cost a month. And given that those patients are on maintenance therapy for many months and years to come, we have to be very careful evaluating PARP inhibitors in the context of cost.